Good afternoon. Welcome to the celebration of the International Thyroid Awareness Week 2021, brought to you by the Department of Health in partnership with Iodine Global Network, World Health Organization, and different societies of Philippine Thyroid Technical Working Group. I am Dali Manalastas from the Department of Health Cancer Control Division, and I will be your host for this fourth day of this week-long webinar series. We would like to acknowledge first the presence of our respectable speakers and participants from different centers for health development, primary care facilities, our colleagues who are joining us internationally, and everyone who is watching our live via Facebook and YouTube. Again, a pleasant afternoon to all. In today's session, as you can see on the screen, the task at hand is to look into the child who had been born by a mother affected by thyroid disorder. We will focus on the child's intellectual outlook, academic performance, and the possible interventions along with it. Also, we will hear the recommendations from the experts regarding thyroid disorder prevention and screening in the workplace. At the end of today's session, we will be equipped with the information from expert speakers coming from Philippine Society of Pediatric Metabolism and Endocrinology, Department of Education, and Philippine Society of Occupational Medicine. And, and before we proceed to the program proper, we would like to present first the webinar guidelines to ensure that this virtual gathering will be enjoyable and productive. So first, kindly indicate your agency, including your country after your name, so that we can recognize you accordingly. Keep your microphones on mute. Turn off your video to prevent distraction, and reserve questions until the Q&A portion. And lastly, stay present throughout the session. Now that the webinar guidelines has been presented, we are now ready to listen to our speakers. To officially commence, we would like to sincerely welcome our first speaker from the Philippine Society of Pediatric Metabolism and Endocrinology, and she is the only pediatric endocrinologist in Mindanao. Let us warmly welcome the previous president of the Philippine Society of Pediatric Metabolism and Endocrinology, Dr. Eleanor C. Du, to present to us the impact of thyroid disorder in the students' academic performance. Dr. Du, the virtual floor is yours. You may now share your screen.
Thank you, Ms. Dali. Okay. So good noon, everyone. In behalf of the Philippine Pediatric Society and Philippine Society of Pediatric Metabolism and Endocrinology, I would like to thank the organizers for making us part of this advocacy. My task is to talk on the impact of thyroid disorder in the students' academic performance. This is the outline of my talk. First, I will breeze through the different thyroid disorders in children. We proceed with knowing more about hypothyroidism before discussing the meat of the topic, which is the impact of thyroid disorder on academic performance. Then we set the management goals, and lastly, I will present to you the take-home points. Similar to adults, thyroid disorders in children can present with hyperthyroidism. This is usually exemplified by Graves' disease. It can also present with hypothyroidism or euthyroidism. This could go with or without goiter. It can be congenital or acquired, or it can be transient or permanent. Now we zoom in to hypothyroidism. For those who have attended yesterday's lecture with Dr. Feliciano, fellow PSPME member and our current president, she has discussed in detail this hypothyroidism, specifically congenital hypothyroidism. Anyhow, the common causes are the following. We have dysplasia, dysharmonogenesis, iodine deficiency, autoimmune thyroiditis, and maternal factors like maternal antibodies, drug intake, and iodine status of the mother. All this can be a factor in development of hypothyroidism for among children. Take note, I mentioned iodine deficiency as one of the factors. However, we don't see much of this and we don't have so much data locally because we don't have a readily available test for iodine levels in our population. This may, however, be an underlying etiology for those children, especially presenting with subclinical hypothyroidism. The symptom of neonatal hypothyroidism are as follows. This is an old scoring chart. The symptoms, if you notice, are non-specific. However, when we see the symptoms together, it will give you a higher likelihood of congenital hypothyroidism diagnosis. For older age group, these are some other signs and symptoms that you will be able to appreciate. Goiter can be a presenting sign of hypothyroidism, usually seen with dysharmonogenesis, those who were affected by maternal condition, and again, iodine deficiency. I highlighted some of the symptoms of hypothyroidism that may have a greater impact on academic performance. We have lack of energy, somnolence, and slow speech. We know that learning needs active participation, so the child should be alert and the child should be able to communicate with peers and with teachers or other people to improve learning experience and thereby improve school performance. So deficiency of this or problems with this characteristic would impair school performance. The succeeding slides that I will present will show how hypothyroidism can impact on the academic performance of affected children. First, know that several factors affect academic performance like genetics, environment, nutrition. All of this plays a very important role in child's learning capacity. But studies would show that cognitive ability is the most predictive and measurable for academic achievement. So cognitive ability can be evaluated by assessing fluid intelligence or the problem-solving skills and crystallized intelligence or the verbal intelligence. In the studies on academic performance, most researchers analyzed achievement in these parameters. So we go now to the evidences from several studies. So this paper compared the IQ of children who were diagnosed to have congenital hypothyroidism with their normal siblings, using McCarthy scales of children's ability and the revised Wechsler intelligence scale for children. Sibling comparison eliminated the difference in genetic and environmental factor. This study has been extensively cited by other researchers if you are reviewing studies on hypothyroidism and academic performance. So results shows the following. Children with CH had lower IQ points especially for those who were athyrotic and those given lower dose of treatment. 8.1 and 66.2 points on McCarthy and WIS CR scores, respectively. So the previous slide showed the findings among 6 to 7 years old. This slide will show similar study among adolescents. Again, same findings. IQ based on general scores, verbal IQ, and performance IQ of the CH group is lower. While for the school-associated performance, the difference was particularly noted in the naming test and arithmetic category. There were no difference in verbal fluency and speed of reading category. Further analysis of this test showed that the verbal IQ was 94.7% in the 12 CH subjects who did not complete senior high school, in contrast to the 105 in the completers. This is a significant difference between the two groups. Moving on, this is a comparison of IQ scores based on severity of congenital hypothyroidism. In the table, it shows that severe CH has the lowest IQ. Severity was based on T4 at diagnosis, skeletal maturity, and type of VH, such as whether they have athyrotic, dysharmonogenesis, and other etiologies. These are the motor scores of the same subjects. It showed significant difference for total motor impairment and manual dexterity, even between moderate to severe CH categories. However, difference in ball skills and balance scores are seen only between severe and normal subjects. This study is again sibling pairs. So as mentioned, sibling pairs is more significant or is more important because it eliminated the factor of genetics and environment. So this sibling pair study looked into outcome at 20 years old based on severity. So there is a close correlation of severity with motor function, while the timing of treatment is related to verbal IQ and school-related tests. So the study I presented were all foreign studies. This one is a local study done by my mentor, Dr. Sylvia Estrada. So thank you, Dr. Estrada. I think she's with us this afternoon. So this is a more detailed study, a local data with a more detailed analysis of the mental development of children diagnosed with congenital hypothyroidism. It showed that there's a high 54% of subjects with delay in one aspect of neurodevelopment. The modifying factors for outcome would include, is consistent with the finding of the other studies. So it's also related to the severity and to the severity, to the follow-ups, and the so it's to the severity and medical management. So it is quite expected that severe hypothyroidism has poor academic performance. But let's see this study about subclinical hypothyroidism. Subclinical hypothyroidism in the study was defined as TSH more than 4.5 milli-IU per liter and a normal T4. So the higher number here in the table would mean more mistakes when the subjects were given the exams. So a more detailed analysis of their cognitive performance showed that they fare equally well with the euthyroid counterpart in memory, but they have more mistakes in language, arithmetic, and visual motor skills. Though this finding is not statistically significant, somehow it shows that even mild hypothyroidism, which can go undetected, may have impact on academic performance. These are the additional factors that can have negative impact on the academic performance in children with hypothyroidism. If the child is prenatally hypothyroid, that is what has been discussed in the previous days, when the mom is hypothyroid herself, so not enough to share or to support the thyroid function of the fetus in utero. If the baby was born premature or with low birth weight, if the medication was initiated late, if there's inadequate or erratic treatment, as what was found in Dr. Estrada's study, poorly compliant to medication would mean that the child will have poor outcomes, and other associated concerns with hypothyroidism. So we have hearing impairment and iodine deficiency. So there is supporting evidence to say that children with CH most likely have damage to the auditory system, specifically involving the retrocochlear structures when compared to healthy children. So we know for a fact that our senses is very important for academic achievement, for learning experience. So if the child has deficiency in hearing, then reception to information can be challenging, and it will compromise learning and eventual academic performance. Okay. So how about iodine deficiency? So our main focus of the main theme of the session is about iodine deficiency, and this is a large meta-analysis study conducted in China. There were 37 eligible studies conducted in 13 provinces of China with 12,614 subjects aged 4.5 to 15 years old. So the results are as follows. So iodine deficient areas versus iodine sufficient environment with no iodine supplementation showed lower IQ points. Iodine deficient areas versus iodine sufficient environment with inadequate iodine supplementation showed 12.3 lower IQ points. And in iodine sufficient area, in the group in which children receive adequate iodine during their mother's pregnancy and after birth, had a much lesser decrease in IQ points, which is around 4.8 IQ points. So as mentioned earlier, we don't have commercial iodine test available locally. So as As presented in the previous talk, however, Philippines is still considered to be iodine deficient, especially in some particular areas. So iodine supplementation is really important to improve IQ scores of our population, which will then translate to, hopefully, excellence in academic outcome. This is a more recent study on the effect of iodine deficiency on academic performance of school children. This study was conducted in Ethiopia. So they concluded that the exposure to long-term insulin iodine deficiency leads to a low school performance of children, increased absence from class, and dropout from school. So iodine deficient children were unable to utilize their full mental potential at school. Okay, so how do we manage babies or children with hypothyroidism? So early recognition is important. We cannot overemphasize that. And hypothyroidism, regardless of cause, should be treated promptly and adequately, especially in the first 3 years of life when brain is still developing, so as to achieve optimum growth, so optimum development of the neurons, and which will translate to better outcome. So this is clear cut for confirmed hypothyroid patients, which are supported by laboratory results of a low FT4 or T4 and an increased TSH. However, for those with subclinical hypothyroidism, though I presented earlier that there are some neurodevelopmental insults already, even if they are in the subclinical state, the treatment is still controversial. Some would opt to treat and some do not. But the general agreement or majority agrees that treatment should be initiated if the TSH is higher than 10, even if the FT4 or T4 is still within normal. So my take-home points for this lecture would be thyroid disorder in children can range from hypo to hyperthyroidism. Hypothyroidism is a significant cause of developmental delay and poor academic performance among children. Severe prenatal onset of hypothyroidism can have worse outcome. And IQ for mild hypothyroidism can be normal. However, specific neurologic and cognitive impairments can influence academic outcome. Iodine deficiency can significantly affect the IQ of children. Iodine supplementation in iodine deficient areas can increase IQ points substantially. Cognitive ability or IQ predicts academic achievement as previously presented. Hypothyroidism and iodine deficiency is a medical and also a social concern. Impact of thyroid disorder on academic performance is undeniable. With strengthened programs for prevention and treatment of iodine deficiency and hypothyroidism, hopefully we improve the cognitive development of our children and academic performance for them to achieve higher excellence in whatever they do. So hopefully we can also do more studies, local studies, especially on iodine deficiency and its impact on our children's academic performance. So thank you very much. Good afternoon.
Thank you once again, Dr. Du, for presenting to us the evidences regarding the impact of thyroid disorder in the students' academic performance. We have learned that hypothyroidism is a significant cause of developmental delay and poor academic performance of affected children. Thank you again, Dr. Du.
My pleasure.
Now, now we are very privileged to have with us another respectable speaker. Um, Kindly unshare your screen, Dr. Du. Thank you. Thank you, Dr. Du. Now we are very privileged to have with us another respectable speaker. She is a medical doctor by profession and has been in the public sector for the past 28 years. She earned her master's degree in public health through a scholarship from the University of the Philippines, Manila. Ladies and gentlemen, please join me in welcoming the Chief Health Program Officer of the School Health Division under the Bureau of Learner Support Services of Department of Education, Dr. Maria Corazon C. Dumlao, to discuss to us optimizing the educational performance and future productivity of a child born with mental challenges. Dr. Dumlao, the virtual floor is yours. Kindly share your screen. Thank you.
Thank you, Ma'am Dali. Good afternoon, everyone. The topic that I've been asked to talk about is optimizing the educational performance and future productivity of a child born with mental challenges. And my approach to this presentation is to walk you through how the Department of Education is optimizing the educational performance and future productivity of its learners with intellectual disability through its policies and programs based on its mandate under the law, especially the special education program and its transition curriculum. In the Department of Education, children with mental challenges are considered learners with disabilities. And DepEd Order number 21 series of 2020 provides this definition of learners with disabilities, which includes those who have intellectual disabilities. Children, youth, and adult learners with substantial limitations in their functions, characterized by significantly sub-average intellectual capacities and or existing concurrently with related limitations in two or more adaptive skills areas. They may have any or a combination of the following: intellectual disabilities, learning disabilities, mental, emotional, or behavioral disorders, sensory impairments, autism, long-term physical or health disabilities, deaf, blindness, and multiple handicapping conditions. These conditions may be a hindrance to the learner's full and effective participation in the society. Thus, these conditions necessitate the provision of special education services and other allied services that will enable learners with disabilities to live functional lives. This is the profile of learners with disabilities in the department. We have 197,030 in 2019-2020. And as to the disability, those medically diagnosed by licensed professionals include impairments for visual, hearing, learning, and also intellectual disability that includes autism spectrum disorder, emotional behavioral disorder, orthopedic or physical handicap, speech, cerebral palsy, special health problem or chronic illness, and also those having multiple disabilities. As to the difficulty based on manifestations, we have difficulty in seeing, hearing, difficulty in applying knowledge, difficulty in remembering, concentrating, paying attention, and understanding, difficulty in applying adaptive skills, or in displaying interpersonal behavior, or in mobility, such as walking, climbing, and grasping, or difficulty in communicating. There are mechanisms in the department in enhancing the educational outcomes and potentials of slow learners. The DepEd Special Education Program for Learners with Disabilities is one concrete manifestation of this commitment to education for all learners. This is further supported by RA 9442, otherwise known as the Magna Carta for Disabled Persons. And the legal instrument expressly stipulates under Section 32, Chapter 8, the provision of educational assistance to persons with disability for them to pursue primary, secondary, tertiary, post-tertiary education, as well as vocational or technical education in both the public and private schools through the provision of scholarship grants, financial aids, subsidies, and other incentives to qualified persons, including support for books, learning material, and uniform allowance to the extent feasible, provided that persons with disability shall meet the minimum admission requirements. Further, in Section 14 of RA 7277 requires the state to establish, maintain, and support a complete, adequate, and integrated system of special education, and directs the establishment of special education or SPED in public schools with funds to be allocated by the national government that will allow its effective implementation in the country. The SPED is designed to develop the maximum potential of learners with disabilities for them to become independent or self-reliant. And it also ensures the acquisition and maximization of learning competencies, as well as the inculcation of values to make them productive and effective members of the society. It shall further be geared towards providing them the opportunities for a full and happy life through adequate, equitable, and appropriate support mechanisms and accommodations. Specifically, the activities of the program aim to equip the learners with disability adequate skills and essential skills, values, and to prepare them for independent living and employment through the provision of adequate and appropriate programs and services, support mechanism, accommodations, and modifications that will address their unique conditions and needs. And it also allows the strengthening of partnerships and linkages with GOs, NGOs, LGUs, and other stakeholders. These are the DepEd issuances on the SPED. We have DepEd Dex Order number 26, series of 1997. We also have DepEd Order number 53, series of 2008. And then we have DepEd Order number 38, series of 2015, guidelines on the utilization of support funds for the SPED program. And the most recent is DepEd Order number 21, policy guidelines on the adoption of the K-12 transition curriculum framework for learners with disabilities. The point shown in this slide highlights the different components of the SPED program. We have the establishment of Inclusive Learning Resource Center. So to respond to the challenges of the time, the DepEd has come up with the establishment of Inclusive Learning Resource Center in all schools division to cater all types of learners in the school and community. And then it also provides personalized supplemental education programs and consulting medical allied services. It has also the multi-factored assessment tool through the O29 series of 2018, which is an activity-based assessment covering the 5 domains: cognitive, communication, socioeconomic, motor, and daily living skills learning. Trained grade 1 teachers conducts the assessment, enhancement, and intervention. The data or results allow for the immediate provision of the appropriate intervention program. And if the intervention made in the school does not lead to improvement and or in academic functioning, the school may refer the learner to allied medical specialists for further assessment. We also have training programs, the institution-based summer training program for elementary, secondary school teachers and school heads, and then training of teachers, administrators, supervisors, and chiefs on inclusive education. and training of the receiving teachers on SPED content and pedagogy, and also disability awareness and sensitivity training for elementary and secondary school principals. There's also a component to provide program support funds on top of the MOE received by the schools to support SPED program implementation at the school level. That includes learner development activities, training, educational visits, camp activities, sports, learning, participation, procurement of instructional and reference materials, early intervention materials, and manipulative materials and other assessment tools. And it's determined based on the enrollment of learners with special education needs. We also have the medical and health services through voucher or bursary system, which is proposed to provide financial support for enrolled learners with disabilities. And we also have the transition program, which are considering the diverse needs of learners with disabilities. Set of competencies are needed in provocational, self-care, life, enrichment, functional, academics, livelihood, and career skills. In order to provide appropriate accommodation for learners with disabilities, transition program is offered to learners from home to school and post-school opportunities. And this involve programs and services that give better outcomes for learners who are eligible to receive it. If the learners with disabilities acquire the necessary competencies, demonstrate appropriate skills, and have access of support services, then it is likely that they will have a more productive life. This is the DepEd Order number 21 series of 2020, the policy guidelines on the adoption of the K-12 transition curriculum framework for LWDs, which articulates the principles, features, and standards that will establish common understanding at the transition of LWDs in all public and private schools. This figure illustrates the transition curriculum framework for LWDs, which considers the needs, the nature, abilities, and capacities and interests of the learners. Thus, it is important to conduct diagnostic assessment to assess the capacity, and this will be the basis in guiding the teachers in giving academic advice in developing the learner's individualized transition package. And the aim is to develop a functionally literate and holistically developed Filipinos. Next slide. As to the entry points, we have the home. This can be an entry point for the LWs who have no formal school experience. So if necessary, learners under this category may take up care skills and life skills packages before taking up other skills offered. The school, this entry point is for learners who have already experienced learning in the regular classroom, but was eventually identified to require careful transitioning and assistance for any valid reason. And we also have the SPED Center or the classes. Those who have shown progress and improvement as evidenced by the reports coming from their ITP and SPED teachers. So we have the desired outcomes or life pathways. They can go into higher education. They can proceed to this exit, and they are assumed ready to take up academic subjects and continue to further education, or they can go into entrepreneurship. Those who will proceed to this exit should be able to acquire entrepreneurial knowledge, skills, and attitudes to make them able to run a small business, or they can go into employment or middle level skills and functional life path. There are skills packages included, and the care skills package contains the fundamental competencies that will enable LWDs to perform independently and develop their potentials to the fullest. So this contains the personal, good grooming, growth and development, health habit and nutrition, and personal safety habits. We also have the life skills package, and this includes communication skills, health and personal safety skills, practical money, management, leisure and recreational skills, community orientation and mobility skills, positive self-concept, human sexuality, and moral development. And then we also have the functional academics package, which focuses on basic academic skills necessary for the enhancement of the learner's participation in school and in the community. Next slide. The pre-vocational package, which prepares and trains LWDs for livelihood, vocational training, or possible employment. And we also have the enrichment package that provides them with opportunities to explore their talents and skills in music, arts, dance, and sports. And then we also have the livelihood package and entrepreneurial activities. And the career skills package designed to assist students in learning the skills and attitudes necessary to be successful. So it emphasizes on decision-making skills and other skills development. For the implementation guidelines, upon the learner's admission to the program, the school shall administer and use appropriate diagnostic tools to analyze the learner's conditions, and then the parents, the transition curriculum teacher, and other helping professionals should agree and set the annual target goal for the learner with disabilities before deciding on what specific package to be given to the learner. And the learner does not need to finish all the contents, but only needs to master the competencies which are deemed essential for him or for her to attain the goals stated in his or her individualized transition plan. We also have the learner support services for all the 26 million learners in the Department of Education. The learner support services formulates the national framework for learner support services and develop policies and standards of programs and projects for the holistic development of learners aligned with the K-12. So under this, we have the School Health Division, the Youth Formation Division, and the School Sports Division. The School Health Division is tasked to come up with the programs to improve learner readiness in terms of physical health and proper nourishment. And these are the um, the function, the statement of its purpose, capacitating our stakeholders on health and nutrition. And there are 6 flagship programs. We have the school-based feeding program and other nutrition support programs, including the salt iodization program. We also have the medical, dental, and nursing services. We have around 4,000 health personnel in the entire country to provide the health and nutrition support and manage health and nutrition programs. We also have the water sanitation and hygiene in schools program, the adolescent reproductive health, the national drug education program with comprehensive tobacco control, and the school mental health programs. So for the school-based feeding program, we provide hot meals and other nutrition support programs that includes nutrition education and the integrated school nutrition model. Next slide. And then the services. Next. The wash in schools, adolescent reproductive health, and the National Drug Education Program and school mental health. All of these wrapped in the program of the department, the Oplan Kalusugan sa DepEd, or OKD, which is a convergence of all of these programs so that the principal can better appreciate the health and nutrition activities. We have the National Salt Iodization Program, which mandates DepEd through the NSIP to intensify its advocacy against iodine disorder, deficiency disorders such as mental retardation, cretinism, and goiter. And we have developed lesson exemplars with UNICEF and the National Nutrition Council. And then we also have DepEd Order number 8 series of 2007 to make the school canteen an avenue to help eliminate malnutrition and develop desirable eating habits. Next slide. And then in that provision, iodized salt shall be used in controlled quantity in the preparation of cooked foods. Next slide. In summary, the Department of Education is optimizing the educational performance and future productivity of children with mental challenges together with other learners with disabilities through the various activities and projects under the SPED, particularly the transition curriculum or program for learners with disabilities. And the transition plan for each LWD is individualized and tailor-fitted according to his or her needs and sets the annual or target goal for the LWD. The specific package to be given to the LWD is aligned with the individualized transition plan. And the learner support services, specifically health and nutrition programs, are also implemented to support curriculum efforts. And these include the National Salt Iodization Program, which intensifies the advocacy against iodine deficiency disorder, such as mental retardation, cretinism, and goiter. So thank you very much for this opportunity to advocate our health and nutrition programs of the Department of Education and support programs to learners with disabilities.
Thank you once again, Dr. Dumlao. It is good to know that parents and families with a child born with disability can really depend on the mechanisms and initiatives of DepEd in optimizing educational performance through special education programs and packages. Thank you again, Dr. Dumlao. Now that we have discussed regarding the impact on academic performance and updates on DepEd's program, let us now listen to our last speaker. He is the National Board Director of Philippine College of Occupational Medicine. He is also the Research Committee Head of the Philippine College of Physicians. Let us gladly welcome Dr. Romel B. Punongbayan to present to us the need for thyroid disorder prevention and control policy in the workplace. Dr. Punongbayan, over to you.
Good day, everyone. So thank you for inviting us at the Philippine College of Occupational Medicine. I'm Dr. Romel Punongbayan, and I will be discussing thyroid disorder prevention and control policy in the workplace. So our objectives for this talk is to present and discuss occupational exposures related to thyroid diseases and the standard surveillance and possible gaps in the prevention strategies. So there are occupations or healthcare or medical workers involving radiation. So these are the established ones who are more likely to be exposed to thyroid diseases like the radiological technologists, the dentists and their assistants, the female nurses, the pharmacists, and the psychologists. And some studies have reported that even farmers or agricultural workers are experienced an increased risk of thyroid cancer. However, studies are still ongoing to find association on this. And also, inconsistently, they also link teachers, economists, and the following work job to have an increased risk for thyroid diseases. So what are the thyroid disrupting chemicals? So upon looking at the literature, these are the ones who are making the chemicals affecting the thyroid process. So the more common is your pesticides like your organochlorine and your DDT. However, in many countries, DDT is already phased out or not already being used. I've looked at several journals regarding exposure of thyroid in the workplace and several diseases like this one, an incident thyroid disease in female spouse of private pesticide. This is about pesticide applicators. And we identified almost 1,600 plus hypothyroid and 500 plus hyperthyroid cases in a 20-year follow-up. And they concluded that several individuals were associated with increased risk of hypothyroidism and hyperthyroidism upon exposure to these pesticides. And there are specific fungicides and chemicals that can cause hypothyroidism, and some can even cause hyperthyroidism. So it's a mixed effect. There will be hyperthyroidism and there will be hypothyroidism. I also look at the evidence on synthetic pesticides and health work health in vulnerable population, the agricultural workers, and they found out they find the same findings that the researchers observed an increased risk of hypothyroidism in certain chemicals as almost the same with the previous studies. And recent findings suggest that exposure to synthetic pesticides may be associated with health outcomes, specifically to the thyroid. However, recent studies on respiratory effects is sparse, and more research is warranted regarding DNA damage, oxidative stress, metabolic outcomes, and specifically your thyroid effects. So this is an interesting case report of occupational thyroid disease. I have seen a case of a 35-year-old female reported to have thyrotoxicosis factitia. Looking at the case, they have seen exposure of iodine in the parlor or in the workplace. So unprotected exposure to cosmetic creams with iodine and even thyroid hormones produce the disease thyrotoxicosis factitia. Then upon withdrawal, slowly withdrawing the patient on this exposure, eventually the disease is treated. So that's the problem I am seeing, that even in the United States and abroad, they have limited capacity to visit workplace, with especially for those with less than 10 employees, as well as here in the Philippines. We are doing our best. The government is doing their best to visit even the smallest group of entrepreneurs. We call it the micro and small industries. However, we're still in the process of documenting all visits to these kinds of workplace. So looking at that, I have seen a data in the Philippine Statistic Authority that in 2016, we can see around 31% registered as beauty parlor. So that's the reason why I focus on this one, because this might be one of the gaps that we are not seeing. The small entrepreneurs like the beauty parlor. Then looking at the profile of iodine, which is related to the exposure of the case report I have presented a while ago, this can be seen in different forms, like in these 10 most common forms of your iodine. So ammonium iodide, potassium iodide, and the rest. These are used in antimicrobial, skin protection, emollient, like this one, in skin conditioners, smoothing solutions, and these are the number of cosmetics that might have the iodine in them. So I've seen a lot of very common preparation. So like your lipstick, they can put 30 brands have 30 brands have potassium iodide in them, like your hair color or bleaching. So why is iodine being cited? Iodine is on the right to know hazardous substance list because it is cited in the international regulatory bodies or organizations like in OSHA, the American Conference of Governmental Industrial Hygienists, the Department of Toxicology, and even in NIOSH. So looking at the workplace exposure limits in OSHA, the permissible exposure limit of your iodine is zero point 0.1 parts per million. And this should not exceed at any time. Like in NIOSH, the same cutoff, zero point 0.1 parts per million. And in ACG, the threshold limit value is 0.01 ppm as inhalable fraction and vapor in an average of 8 hours, and zero point 0.1 ppm, the same with the previous cutoff, as the vapor as a STEL, or we call it the short-term exposure limit, or less than 15 minutes. However, the caveat here is the above exposure limits are air levels only. When skin contact occurs, you may be overexposed. So even with a small amount in the air, an exposure in the skin could be very significant already. So determining your exposure, of course, you have to read your manufacturer's material safety data sheet, or we call it in OH, occupational health, as MSDS. For medical testing, for those who are frequent or potentially highly exposed to this, we should always monitor the liver and kidney function test. And if symptom develop of overexposure, we can also evaluate using your chest X-ray for acute exposure to see the lungs, and it's specifically to evaluate the thyroid function test. So these are other acute health hazards of your iodine exposure, as well as your chronic health effects. How about cancer hazard? While iodine has been tested, it is not classifiable at this point as to its potential cause to cause cancer. There are also effects in the reproductive tract and other effects in the body, like allergies, which is represented by your skin rashes, and I have seen a journal looking at the dose and regulatory issues of radiation. Since one of the more common exposure for thyroid cancer or thyroid diseases is ionizing radiation, I've seen this journal in 2018 looking at the health impacts of low dose ionizing radiation, current scientific debates on regulatory issues. So they have seen that the safety regulation is based on linear no threshold, or we call it the LNT. However, this is by far not the best way to protect the public health. So they are looking at better ways on how to really do regulations of this harmful radiation. So another way of this is the ones we are using at present is to establish a radiological protection system. One is to justify the practice, so meaning it's a benefit versus risk, which the benefit should outweigh always the risk of being exposed. The optimization of your protection, meaning the lesser number of workers to be exposed, the better, and individualize those limits. So different kinds of exposure should have individualized or specific dose limits. So this is a one also of your control for irradiation, your current dose limits. So those limits are required to limit total dose, especially where occupational exposure is several, especially for those with several exposure to radiation. And also limit uh, occupation exposure in emergencies, because in these cases where multiple or severe exposure to radiation is being looked into. So I also look at a journal of the increased incidence of thyroid cancer among World Trade Center. This is very interesting. This is a descriptive epidemiological assessment after the World Trade Center attack. And they have seen that cancer surveillance of the World Trade Center first responders should continue. However, they have seen a lot of thyroid cancer after the event, and after looking into it, it is more of over-reporting, because most of them has respiratory symptoms because of the dust, the fumes of the incident, and upon workups, they incidentally found out that there are a lot of workers or your first responders to have thyroid diseases. So this is another interesting case report, melanoma, thyroid cancer, and gynecologic cancers in female flight attendants. They have seen in 6,000 female flight attendants using your Cox regression analysis about the relationship of melanoma, thyroid cancer, and gynecologic cancers in female flight attendants. And the results, the incidence of thyroid, ovarian, and uterine cancers was not elevated. And they concluded that there's a little evidence of increased risk of these cancers for occupational cosmic radiation and circadian disruption of the female flight attendants. However, limitations should include few observed cases for some cancers. There's a limited data on the risk factor and probably a misclassification of exposure, because some of the workers might already have a predilection to thyroid diseases. So my recommendation is to reinforce administrative controls, specifically training for material safety, even in the small and the micro industries like your farmers, your beauty, your cosmetologists, or your beauty parlor workers. Reinforce other control measures like substitution of materials if possible, and it's not limited to personal protective equipment. Do a focus rather than a mass screening of thyroid disease. Then because of this, you have to have a good history in PE, and we cannot overemphasize that. And I also recommend that we have to make more researches to prove a specific causality of thyroid diseases in the workplace. Remember that thyroid diseases usually are chronic and requires a long exposure. And just because I may look like an average person does not mean I am. I am battling an illness and working harder. You could ever imagine to have a normal life. Looks can always be deceiving. So not we always check the ones that are not seen by the naked eye. So with that, thank you for your virtual attention, and I think this is the time to stand and stretch. Thank you very much for your having us. These are my sources.
Thank you very much, Dr. Punungbayan, for enlightening us that thyroid health and safety should be prioritized in every workplace, and thyroid disorder prevention and control policies must be well implemented. Now we are opening the floor for questions as we have three live speakers. First is Dr. Eleanor Sidu from the Philippine Society of Pediatric Metabolism and Endocrinology, Dr. Corazon Sidumlao from the Department of Education, and again, Dr. Romel Punungbayan from Philippine College of Occupational Medicine. Again, please type your questions in the chat box and please address them as well to our speakers so that we can line them accordingly. So I think we have one question here from our viewer addressed to Dr. Du. The question is, do you think that research on the effect of untreated hypothyroidism in pregnant women on the school performance of their children should be prioritized here in the Philippines?
Yes, Ms. Dali, thank you for that question. You think that more people will really advocate for that because we really don't have a test for iodine levels in our population. So with lack of evidences, lack of studies, we don't really know what the real picture is. So it would be better if we have more evidences, make iodine testing available, more readily available, because so that we can identify the problem and do something about it.
Okay, thank you very much, Dr. Du, for that. And I think we have another question here for Dr. Dumlao of DepEd. The question is, where can we call or go to further know the details regarding the special programs of DepEd for children with disabilities? Dr. Dumlao.
Department of Education is centralized, meaning we have several layers of governance. We have the national level, and then we have the 17 regional offices, and then we also have the division offices. So it depends on the area, the location. You can coordinate with the schools division offices for the details of the SPED development, the SPED program.
Okay, that is well noted, Dr. Dumlao. And I think we have one last question here for Dr. Punungbayan. The question is TSH testing routinely done in female employees presenting signs and symptoms of thyroid disorders?
Thank you
Dr.
for that. That is a very nice question. Actually, in occupational health, there is no really one size fits all. So aside from regular testing of your routine testing like your CBC, urinalysis, fecalysis, and chest X-ray, everything should be fitted for the patients upon evaluation. So we have to treat and dress accordingly if you see a patient symptomatically. And in addition to this, one also very important task of occupational health physician is to evaluate what is the possible risk factor or exposure in the workplace and try to control them in order to prevent our workers to get sick. Okay, so that's the more difficult part of being an OH physician is to survey the workplace if there are risk factors or exposures and try to control them. So if you see a patient with symptoms of probably a hyper or hypothyroidism, you still have to address it accordingly because all of the workers are regular adult patients. So the only addition to the OH practice is to look on the workplace if it's contributing to the condition of the patient. So that's it.
Thank you, Doc Punangbayan, for those recommendations. And I think that concludes. Oh, I think we have one more question here from Dr. San Luis. I think this is for Dr. Punangbayan as well. Are company physicians doing neck palpation of their employees at all?
Yeah,
Doc
so that's
Punangbayan,
a
please.
good point. That's a good point. That's the reason, sir, that I in my end in my last slide, I really emphasize, we cannot overemphasize to do still a very thorough history and physical exam. It's not an excuse to do it in all the disciplines of medical practice. Included to that is occupational health. So it's but prudent and vital to do still a very thorough history and physical examination.
Okay. Thank you for that, Dr. Punongbayan. And I think that concludes our question and answer portion. Thank you everyone for participating. And at this juncture, as we have reached the end of today's session, we would like to call Dr. Clarito Cairo Jr., the Medical Officer for of the Cancer Control Division, Department of Health, to present the Certificate of Appreciation to our speakers. Dr. Cairo, over to you.
Yes, thank you, Dali. Good afternoon, everyone. The Department of Health awards the Certificate of Appreciation to Dr. Eleanor Du in grateful appreciation of her invaluable contribution as our distinguished resource speaker on impact of thyroid disorder in the students' academic performance on May 27, 2021, during the week-long virtual observance of International Thyroid Awareness Week and World Thyroid Day from May 24 to 29, 2021. Signed by Dr. Maria Rosario Vergere, our Undersecretary of Health, Public Health Services Team, Department of Health.
Thank you.
Thank you very much, Dr. Du.
Thank you.
The same certificate is awarded to Dr. Maria Corazon Dumlao for her fantastic talk on optimizing the educational performance and future productivity of a child born with mental challenges. Thank you very much, Dr. Dumlao.
Thank you po, Doc.
And the last but not the least, the same certificate is awarded to Dr. Romel Punongbayan for his excellent talk on the need for thyroid disorder prevention and control policy in the workplace. Thank you very much, Dr. Punongbayan.
Thank you, sir.
Over to you, Dali.
Thank you, Dr. Cairo, to our guest speakers, and especially to all participants joining us in this fourth day of this webinar series. And now let's have a quick photo documentation. So maybe request everyone to turn on your cameras. And I think we have Sir Joram here to take our photos. So we can have the slide, the gallery view. And I think we have 8 slides here. Sir Joram? Okay. Let's have the first slide.
Okay. Second slide. For the third slide. For the fourth slide, please open your videos. And last for the fifth slide. Okay, thank you.
Thank you, Sir Joram. And now to give a glimpse of our 5th session tomorrow, as you can see on the screen, we will have again a distinguished speaker from the Philippine Society of Endocrinology, Diabetes and Metabolism to discuss the early detection, prompt referral, and management of thyroid disorders. We will also hear from the president of the Philippine Thyroid Association to close this 5-day webinar series. So we hope that you will join us again tomorrow as we continue to celebrate the International Thyroid Awareness Week. As you will see on the next slide, we have here the same link, or you may scan again the QR code. And the next slide will show us the survey form. So please help us further improve our learning sessions by completing this feedback survey. On the next slide, please. Okay, so you may take a picture of this QR code and please answer the survey form, and after that you will receive your certificate. So I think we end the program here. Thank you once again for joining today's webinar series. Good afternoon and stay safe, everyone.